why did the progesterone get low? It's not, so a lot of times, like, I just have this hormonal imbalance. You don't just have this hormonal imbalance. Your hormones didn't just get imbalanced out of nowhere and suddenly it dropped. There are, because if that's the case, then either A, we can't fix it, or B, just take progesterone and everything will be fine. This is the Medical Disruptor, the show where MDs, NPs, PAs, and researchers tell us how they broke the rules because they couldn't find answers in the system they came from. My guests are science-trained innovators who chose the truth over tradition. Real talk, real science, no gaslighting. I'm Dr. E, the NP with a PhD, and I'm committed to making sure women never experience medical gaslighting again. Because here's the truth. When you've been told the same story long enough, you start to believe it. And this show is here to help you challenge your own medical beliefs, especially the ones that were never really yours to begin with. And today's guest is no different. She's a true medical disruptor. You are about to meet someone who checks all the boxes, board certified, classically trained, respected in the system, and then she walked away from all of it. Why? Because she realized that handing out meds wasn't solving problems. It was just managing the decline. Today on The Medical Disruptor, I'm joined by Dr. Erica Armstrong, founder of Root Functional Medicine. She's here to break down the connection between PCOS and thyroid disorders, and more importantly, how she stopped just managing symptoms and instead started practicing real root cause medicine. We're not talking fluff. We're talking glucose curves, beta-glucuronidase, DHEA, magnesium, and some serious real-world results. If you've ever been told your labs are normal, but you still feel like garbage, this episode is your permission slip to stop accepting that as the final word. Let's get into it. Erica, it is a pleasure to have you here.
Thank you.
So, we're going to talk about the PCOS-thyroid connection, of course, because I know that that's your jam. But this wouldn't be the Medical Disruptor podcast if we didn't first discuss how you became a disruptor, because you were board certified, not in disruption. So tell us about your journey. Like, you were traditionally trained. Tell us a little bit about that.
Yes, I was a family medicine doctor for several years, and I saw a variety of patients from newborns to the grandparents, sometimes all three generations in one room. And I loved being a family doctor. Actually, I loved the relationships that I had. But what I noticed over time was that I wasn't truly fixing problems. I was just like delaying the progression of them. And I would watch my patients kind of slowly escalate in their medications. They would get side effects from that, and they would have a constellation of symptoms that I couldn't blame it on a particular diagnosis. So things like brain fog, weight gain, fatigue, sometimes rashes, bloating, all of these things that I didn't like having the answers to. And so I did find functional medicine through a friend, almost 10 years ago now, and started training and piecing that in. Ultimately, I could not fit that model of care into this very regimented conventional model with all kinds of
Oh
restrictions
my
and
God, it's so
like,
true.
yeah, what you can order and like how much time you can spend with people and those types of things. And so ultimately, I decided if I really want to practice like this, I have to go out on my own.
Absolutely. Okay, so I just have a question here, because a lot of my disruptors will have an aha moment. They're sick or someone in their family's sick. Are you saying that? I guess my question mark is like, this just came out as a curiosity because so many of our colleagues stay indoctrinated, never questioning this. So where did that question come from, where you were like, is there something more? How did that come about?
Natural born skeptic. Um,
Yeah, okay.
I think I was always curious, and I was always very interested in nutrition and just like my own philosophy of taking care of myself. I was a college athlete, and I just wanted myself, I would have chosen a natural approach whenever possible. So I think it was a combination of like personal preference, being curious, and then learning about this other way from a friend. And I will say, like, when I went to my first functional medicine practice, like I wasn't like sold on the first day.
Yeah, you were like, this is,
Yeah, it sounded really interesting, but it took a lot of digging. And then the first results that I was getting with people, I was like, oh, this can't even be true. This is like some kind of coincidence or something. But then
yes, you have to
it was
be.
just like keeps happening. And you're like, okay,
What was your
there's something.
initial resistance? Like, when you were like, I first saw it, what were you thinking? Like, why won't this work? What was your thought?
we're taught to really follow evidence, and it's hard to study these interventions when you're studying a single medication. That's easier to control the rest of the variables. But like when you're studying, like recommending 5 different things at once and changing
True.
lifestyle,
True.
that's harder to figure out what it was that helped.
It's true. You're right. We do put a lot of variables in there because we're specifically in functional medicine, we're trying to get out of this A to B. If you do this, all will be right. We understand that there's so many things, and that is so hard to study. Dr. Bredesen, who's like the godfather of Alzheimer's, I don't know if you're familiar with him. He said that this is exactly why, even though he has so much success, he was not able to get any studies funded because there's too many variables. Which is literally the whole point. Like, it's never one thing. It's never one medication. It's never anything. So for you, it was like, how do I, it's the indoctrination of what is considered science has to be this really, I don't want to say diluted, but simplified, if A, then B. And if you can't plug it into if A, then B, then it lacks evidence, which is really hard. And so then even though you saw it maybe 10 times or 20 times, you have to put it into, that's anecdotal, which is a really bad word.
Yeah. Yeah.
Anecdotal medicine is terrible medicine. Seeing people get better, but not quantifying is terrible medicine. Amazing. Do you remember your first few cases when you were like, I think this is working?
I do. Some things, it's funny because I'm actually married to a surgeon who is very conventionally trained, and
Oh, yeah. I'm married to one of those too.
Very,
Not a
very
surgeon, but
conventionally
conventionally trained person, yes.
Yeah. And I came home one day and I was like, I think I fixed carpal tunnel. He's a hand surgeon. He was like, he's like, that's an anatomical problem.
How dare-
And I was like, yeah, I actually didn't believe it either. But like all of her all of her symptoms went away. All of her like inflammation went away. And I was like, it must be inflammation of the nerve that got better. And what we did was we did some extensive food sensitivity and custom elimination diet.
Yeah.
And it got better in 10 days. And it stayed resolved. I think we saved her a hand surgery.
I'm sure it did. And also, the first thing they do is also inject steroids, which is
Exactly. Yeah. Yeah.
anti-inflammatory. So
Yes.
amazing. Oh my
He's
God,
heard
that's
enough
so
of my stories now that he does believe, but yes.
I love it. Like anatomical. Absolutely. I will be okay with some of your nonsense, but I draw the line here, Erica. That's terrible. Yeah. And so then you do it a few times and then you're like, I might be onto something. But then did you also get to like, so at first you're killing it and better, but then you get the patients that you're like, they're not getting better. Did that happen as well?
Oh, definitely. Everyone is on their own healing journey and there's setbacks, and some people are going to be faster than others, especially the length of time that they've been dealing with it. I think that you can always get to some level of optimization, though.
Yeah.
Even if we couldn't fix everything, we could make things better to a point where their quality of life got better. It just, time and patience and a lot of coaching. And we have dietitians who do a lot of that with us, and that team approach really helps too.
I love that. And I promise we're going to get to PCOS. Of course we are. But I'd like to dig into kind of the narrative behind this because I want to surface all these disruptors like yourself around the country because it's a movement. So did you have a hard time? One of the things I have a hard time with, I do not practice functional medicine anymore one-to-one. I just speak on stages, I have podcasts, and I give things away for free in this respect. But I still practice primary care once a week.
Oh, wow.
And it is very difficult to do because I'm fully aware of what I'm seeing in front of me. I'm seeing people who are very ill, who don't even know how sick they are. But I'm also disheartened sometimes by the unwillingness of the patients to do this in the primary care setting. Like I feel that I'm sitting there, I'm going, I have the answers for you. Please just take them. And there's this unwillingness. Did you experience that?
We are in a bit different setting. We started out as D2C and we're a membership practice. So we did get people who were seeking out functional medicine. A lot of the people that we saw, they already exhausted the conventional options.
I meant in your family practice before you opened.
Oh, and family medicine.
Family medicine.
Oh, sure. Yeah, I mean,
yeah.
Yes. Yeah, that wasn't uncommon. I also felt though at the time, like I didn't have the same tools that you did. I didn't actually know how to trigger behavior change or, I
so
just
you're saying that when you practice family medicine, You didn't
Yeah.
have this conflict yet. You didn't know how much you know right now.
Exactly. Yeah. Yeah. It
And the
wasn't until the
benefit.
end till I started to piece it in more, but it was so hard to do that in the restraints that we were in.
So let's talk about that because, which is really important because I try to bring as much as I can to primary care, but it's really impossible. Can you tell everyone listening why is it impossible? You know what? Why can't you bring it into primary care? Why can't you put it into family medicine? Like, why do you have to open a different type of practice?
Yeah, I think number one is sheer volume. When I was a family doctor, I had 2,700 patients under my panel. I was seeing over 20 people a day in 7 to 8 minute visits and charting and messaging and results coming in from specialists. And it's really hard to think outside the box in that type of setting. And so, like at Root, we see 6 or 7 people a day, and that's a functional medicine practice. If your doc is seeing 20 people a day, they're not actually doing functional medicine. There's just no possible time way to do that. And the second thing was like, you can really only order labs that are covered by insurance a lot of the time, because otherwise people get these huge bills and they're very upset with you when they get a surprise bill for $2,000, even though you would have no way to know if it was covered or not. And so it was just really hard to get the right data to make those kind of informed decisions for guiding the next wellness plan.
Yeah, and so this is an important thing. I had a patient come in. So at this point, my team has to really screen any new patients that come aboard to let them know, even though you saw Dr. A on TikTok or on podcast, she is not doing functional medicine here. It's primary care. But inevitably, people like this and they show up anyway. So I had this patient come in and she was really struggling. And what I was trying to explain to her, and I want to surface this and then we'll move on to the other topics, that your doctors are not mean people in the conventional medicine setting. They're handcuffed. Like I also currently, like there's handcuffing. I have to follow certain protocols. I have to follow certain guidelines. I have to make sure insurance covers what you're saying. And we have to send you for certain screenings, certain tests, and we can't send you for others. And everyone is stuck in this maze, and there really is no malice. And there is no way that I have seen, and I've talked to a lot of providers, there's no way that I've seen it successfully being done in an insurance-based model.
I've seen people try and then they end
Try.
up closing down because it just doesn't work for
It's just,
several reasons. Yeah.
and time. You just need time.
Right.
And have that. Okay, so how did you solve all the things that you did? You have your family, you're treating all these multiple diseases. How did you end up landing on PCOS and thyroid? Like,
The dietitian that started Root with me, this was actually her passion coming in. She had done training in PCOS, and it just so happened that the people who were finding us had a lot of those symptoms coming in that we put in some screening labs into our initial lab panel that we were doing. So a DHEAS and a testosterone level. And we'd also had a full thyroid panel in there. And what we found was amazing, actually. We were diagnosing so much PCOS and so much thyroid, and often together. And we were like, oh, what is this kind of connection? And if symptoms weren't resolved with PCOS, we would really try to look at the thyroid because the symptoms are overlapping. And what we found really is both conditions are ultimately an inflammatory condition. And so they share the root cause of inflammation most commonly. And we did our typical Root baseline protocols that we personalized, but we did our Root approach and it was helping reverse these symptoms. Sometimes, if we caught the thyroid dysfunction early enough, we could stop it from progressing into a full blown autoimmune disease attack.
I love that. So you're saying inflammation, but I'm also thinking, and perhaps you mean it, this under that umbrella, nutritional, right? PCOS is oftentimes a carb overload, just to simplify. And thyroid is oftentimes fueled by a gluten overload, other things. And please, if you don't agree, feel free to tell me that. And so I feel also like they're very tied nutritionally, almost like nutrition fuels both of them, not necessarily that one fuels the other. But are you saying that there is a link between the two of them as well?
There's definitely a nutrition component. About 70% of PCOS is related to insulin resistance, which I think is what you were alluding to. And interestingly, inflammation itself can drive insulin resistance. So
Fair.
it's a cycle, but they're both very connected. And insulin resistance affects the thyroid too, and the way that the hormones interact. So, if you're not producing progesterone because you're not ovulating, you have this estrogen kind of dominant picture, and that affects thyroid function. So the two hormone organs are very related to both root causes and how they interact and function.
So I guess I want to understand, like, I get that there is this issue, whether it's nutritional or inflammation, that is now downstream affecting both the PCOS and the thyroid. But if you can connect, so you're saying the PCOS and then affects the thyroid as well. There's this connection, this triangle this way as well.
Yeah, so hormone imbalances affect autoimmune conditions. So I'm going to step back. And so, like most thyroid conditions in the US are caused by an autoimmune condition called Hashimoto's. That's where your body makes antibodies against your own tissues. And so, a lot of times, these antibodies are stemming from the gut, which is where the largest part of our immune system is that makes the antibodies. And so, certain things affect your level of autoimmunity. And one of those big things actually is hormone imbalance. So if your hormones are imbalanced, especially lack of progesterone, we find that's why like after pregnancy is a big time for autoimmune conditions, or in perimenopause when those levels are shifting and the progesterone is dropping. So similar with PCOS and thyroid is that there's this root cause of inflammation, but then like also there's this imbalance of estrogen and progesterone that may make it more likely to develop an autoimmune condition.
Interesting. And by the way, is it progesterone dropping or is it estrogen dominating?
So, in order to make progesterone, you have to ovulate. And so, women with PCOS, they often don't ovulate. That's the reason that they have irregular cycles, because a normal cycle is you ovulate and then progesterone is produced. If that egg is not fertilized, progesterone will drop, and it's the withdrawal of progesterone that triggers the period. And so, like, you have to ovulate to get the progesterone. And so, relatively, if you have very low progesterone, your estrogen will be higher. And so, they're like yin and yang. So, estrogen makes the uterus thicker, progesterone makes it thinner. And so, then that's why sometimes if there's irregular periods, sometimes they're heavier periods because you have a thicker lining to shed.
So I get that part. I guess I'm just wondering, like in the root cause, when we say progesterone dropping, it was my understanding that it's more about the ratio. Because estrogen is elevated, that is causing it to look like progesterone dropping. Are you saying that just the progesterone, so we have this elevated estrogen, elevated testosterone, now we're not ovulating, and therefore the progesterone is dropping? But to begin with, it's not like progesterone just dropped out of nowhere. We had to have this other estrogen dominant kind of world to happen, no?
I think that what you're saying is partially true. I think that the reason that ovulation doesn't happen is a number of reasons. One of those is what we found is inflammation affecting egg quality, because in order to ovulate, your body has to decide that there's an egg of quality to be released to achieve pregnancy. And so one of the ways we work on PCOS and thyroid is to improve egg quality. And so the reason for not ovulating could be various, but if you don't ovulate, you don't produce progesterone, which then creates a relative abundance of estrogen compared to progesterone. There's some other kind of complicated.
The reason I'm hounding on this, and
Yeah.
I know we are oversimplifying, both of us purposefully, because we have an audience to listen to. But the reason I'm doubling down here is because I want to, a lot of times women come to me with PCOS and it feels like just this hormonal imbalance just happened. And like my progesterone is just low. Great. So if I just give you progesterone, everything's going to be fixed. No, like we have to be like, but why did the progesterone get low? It's not. So a lot of times, like, I just have this hormonal imbalance. You don't just have this hormonal imbalance. Your hormones didn't just get imbalanced out of nowhere and suddenly it dropped. There are things, because if that's the case, then either A, we can't fix it, or B, just take progesterone, everything will be fine. And so I was just trying to get like more upstream to the downstream to get us here. But I think we're there.
Yeah.
I think we're there.
Yeah.
Because I feel it's so disempowering for the patients to come in and they're like, not your patients, the patients who are not getting into functional medicine. And they're just like, my hormones are unbalanced. I was told, they come in from their GYN and they're like, oh my God, I was told I have PCOS. And it feels like this thing that happened, like a cancer diagnosis, like this thing that happened, this thing that is just suddenly imbalanced in their body. And then they're given metformin or birth control pills as if, like that's going to fix it. But what I'm trying to surface for anyone listening is it didn't just happen out of nowhere, because that's such a disempowering thing. There are so many things that happen to get you here that you have control over.
Right.
And okay, so you accidentally discovered through your screening that many of your women are coming on PCOS and Hashimoto's. And you're like, okay, so this became your predominant avatar. And so what's the first thing that you do with your patients?
Balanced blood sugar. No matter what your root cause is, it will help you feel better. So some PCOS is caused by different things. And we mentioned insulin resistance, but adrenal glands also produce something called DHEA, and that turns into testosterone, which can drive PCOS symptoms. And so blood sugar balance is going to help almost every root cause, I would say. Mitochondrial health, even gut health, it would help with blood sugar balance. And so what we're doing with this is we're working on reversing insulin resistance, and we're also working on that stress response. When you have imbalanced blood sugar, the body's natural response to low blood sugar is just to secrete a bunch of cortisol because your brain thinks you're dying because the brain needs sugar. And so it's a stress response. And so if you're having fluctuations all day, you're having cortisol spikes all day, which is interfering with your adrenal gland function. And so step number one is balanced blood sugar.
How do you like to do that?
We have a root plate method that we use. We actually patented this because we love it so much and we've been using it for 6 years. But essentially, if you think of a plate, you draw a line down the middle. Half of it is non-starchy vegetables. A little less than a quarter is your starch and starchy vegetables. And then a quarter of lean protein and 1 to 2 tablespoons of healthy fat. And that creates this really great protein, fat, and fiber at every meal and snack.
I'm curious why you decided lean protein and then fat separate as opposed to a fatty protein.
Yeah. I think there are healthier fats that you get when you include like olive oil and ghee and avocado oil, and even nuts and seeds have some healthy fats in them, or I guess salmon could be both actually. So, yeah.
Interesting. Is it like to try to stay away from a particular type of protein when you went lean? When you said lean protein?
No, not necessarily. We would recommend grass-fed beef if you were eating beef, but otherwise, yeah.
So what do we mean when you say lean protein and this root plate method?
Yeah, that's a good point. So, for example, some people put beans in the protein category. We actually put them in the starch category
Yeah.
because they have 3 times as much carbs as they do protein. And so that to me is not a lean protein. A lean protein is something that's like just protein, not a little protein and a lot of carb.
Understood. So you want it to be more protein.
Yes,
Okay.
exactly.
Like net protein. Give me the net protein. I got you.
Our goal is like 30 grams a meal of
30
protein.
grams a meal.
Mhm.
And do you have a daily goal that you like for everyone to get?
Yeah, we do personalize it. There's a calculation you can make to, I think, at least 1.1 to 1.3 grams per kilogram per day.
Yeah. So what would you say is like, just throw out a goal for people who can't do math?
Yeah. So if you did 30, 30, 30, you'd be at 120. So that I would call that a success.
Yeah, I would call it success too. Very hard to achieve.
Mhm.
I would call it success too. So how about continuous glucose monitors? Do you like to use those?
We do. We use them all the time.
Yeah.
Real-time data can be very eye-opening.
That is my learn for 2025 is CGMs. I spent years telling my oral medication diabetic patients, telling them for years that they don't need CGMs because they're not on insulin. So why would they need that? And I was so wrong. I was so wrong because not only do diabetics need it, but everybody in America should be on a CGM. It is so eye-opening, things that you don't think that you're not calculating. And I see it, I see it as soon as people come off the CGMs, they go back to their old ways because the brain is amazing at what it convinces you to do. CGMs are powerful habit changers. There's nothing like real time. So different than the A1C.
Yes.
So different.
3 months to change versus 1 meal.
Yeah, and so you average. Do you have a particular company that you like to use?
I've been using the Stello, the direct-to-consumer one lately.
Nice. Okay, so the first thing we do is get them less insulin resistant and manage their blood sugar. What's next?
Yeah, and having an addition mindset too. So if you're inflamed, your body needs antioxidants, phytonutrients to calm that. And so we focus on getting those different color veggies on the plate.
Did you say addition mindset?
Addition, yes.
I
like
love
add,
that,
like
as
what
opposed
can
to
you
just
add?
restriction. That's
Exactly.
really
Yes.
important.
So important, especially with PCOS. A lot of these women have been told just lose weight. And so they've been on restrictive diets and they're depriving their bodies of what it actually
Yeah.
needs to heal the inflammation. You can't just eat less of the same types of food. It doesn't work.
This is my exact, I don't know where you land on this. I don't know where this is going right now, but I'm just throwing it out there because it's what I do. But this is exactly my argument for people who are using the GLP-1s for weight loss. I feel like you've missed the forest for the trees. Like you're just trying to lose weight, but where's your nutrition? I'm not talking about people who are using it for type 2 diabetes, whatever, but to just lose weight, that is the wrong thing. Like we should be focusing on nutrition, not on losing 5, 10 pounds. Like what are we putting in? What are we taking out? I don't know. Where do you land on that?
No, I agree. We're not setting them up for success if we don't lay that foundation. We know that after a year, over half of people are going to be off of them. And now where are they from where they started? Now they have less muscle mass. So their metabolism is worse off than before
Yeah.
we even gave them this medication. And I think for the right person, like it can be really helpful, but for the vast majority, like we definitely need to get in there and do some other interventions that actually can help long term. And maybe the medication is helpful as a kickstart, but we know that they're not going to be on it long term, even though it's promoted as a long term medication. It's
Yeah.
just not what's actually happening.
Yeah. And they're malnutrition when they're done because they
Yes.
can't eat, so we can't get the nutrients. And this idea of addition is so important because I tell my patients all the time, I really don't care about your weight. Again, I'm not talking about morbidly obese people where obesity itself is inflammatory and is a problem, but the weight that people obsess about, I just care about your nutrition. And wherever that lands you on the scale, I just care about your nutrition.
Yeah, your metabolic health. Are you
Yeah,
inflamed? Do you have insulin resistance? And yes.
absolutely. And we all know that we have very thin people who are very ill with who are
Mhm.
insulin resistant and vice versa. So I'm glad you said addition. Okay, so we have addition. How do supplements play a role in your world?
Yeah, because of our lab panel, we can really target nutrient deficiencies. And so we find a lot of zinc deficiency
Interesting.
in PCOS. We also find a lot of magnesium deficiency. We'll often use those. And then omega-3, almost everyone has omega-3 deficiency unless they're eating fish like 3 times a week, which most people
Most
are
people
not.
don't. What lab or what test do you like to run for nutritional deficiencies?
Yeah, we actually put together a panel through Quest Diagnostics. We call it our root cause panel.
No
And it has the
way.
most common nutrient deficiencies on there, as well as the full thyroid panel, inflammatory markers, metabolic markers, and more.
That's great. And their levels you find are accurate?
Yeah, I do. And they even have an RBC magnesium, which is great. So Quest has really expanded their diagnostic testing capabilities.
That's great. It sounds also like zinc and mag will probably be covered. It's not like it's genetic. Sometimes APOE is not covered, some of the more complex markers.
Yeah, we actually just have a direct contract. And so we're able to pass on really great prices on our labs to our members. So it ends up saving them thousands of dollars and no surprise insurance bills, which is
Oh my
always a
God,
good
that's
thing.
great. That's amazing. So then you can really tweak. Do you then do follow-up labs to see if like it's improved?
Yeah, definitely. Like in 3 to 6 months. We also follow symptom scores, which is
Sure, of
very
course.
telling. But
But it's nice to see because especially with supplements, sometimes people don't feel a difference. And you're like,
Mhm.
that's okay. We still need it even if you don't feel it. That's okay. It's nice to be able to see. People need to see measurements.
Right. Yes.
I love that. Okay, so what else? What else do we what's next?
Yeah, I think you touched on number two, which was replacing the nutrient deficiencies. Number three, I would go to gut health. This is often the root cause of like most conditions. And so much happens in your gut that's related to hormones. So we will often do functional stool testing, because we find different patterns. And so sometimes we find like really low beneficial bacteria. If you have really
Mm,
low beneficial bacteria, the way that you're metabolizing estrogen is going to be different. Sometimes we find markers like elevated beta glucuronidase. If you have that, then more estrogen is getting reabsorbed. Or just general imbalances. Sometimes we find things like SIBO that's causing inflammation, or oftentimes we find gluten sensitivity. We could talk about
sure. What
that,
do
but it's related to Hashimoto's.
absolutely, and I want you to say more about that in a second. What test do you like to use?
We've used a few different ones. We like GI Map, we like Genova's GI Effects. Both of those are the more common ones.
So before we get to the gluten Hashimoto's connection, which I really want to talk about, you mentioned, I want to make sure our readers, our audience is aware of what you said about estrogen and also beneficial bacteria. So just kind of as a recap, I know my audience is really savvy, but we're looking for how much of the good stuff we have versus how much of the bad stuff we have. So it's not just about having pathogenic bacteria, but if you don't have enough of the good stuff, the reason why we take probiotics, that's going to be a problem. But beta-glucuronidase, I'm loving that you mentioned that too, because if any of you listen to my podcast, we talk about this, you know, how we, I'm going to say metabolize, but that's not the word, how we metabolize certain things, including like hormones, and the phase 1 and phase 2 of how things get excreted ultimately. And all that has to happen. The gut is a big part of that. And if it's not getting done properly, especially if you're on hormone replacement therapy, you'll be taking all these hormones and it's not being processed the right way or packaged the right way. So if you're anyone who's on hormones, your gut health has to be on point. Even just taking the hormones themselves is not enough. And in that, do you also, one thing I haven't heard you explicitly mention, but it's on your plate regardless, is fiber.
Yes.
Because fiber plays a big part of it. Is that something that you count? Is that something that you consider?
Yeah, our dietitians are great at helping people gradually build up their fiber, because if you go from eating the typical American diet of less than 10 grams of fiber a day to eating 30 grams, you're going to be bloated and feel miserable. So you have to titrate it up. But like you said, like it's so important for hormones because fiber will bind estrogen and help you remove it when your body's done using it.
Yeah. What kind of fiber do you like to use besides vegetables?
Yeah, I think chia seeds are actually one of our favorite sources of fiber. Raspberries, especially summer's coming up. A chia pudding with raspberries would be a really great source of fiber. We have used some fiber powders. We like sun fiber, different blends. Different fibers do different things. Actually, your good bacteria eat them and create nice layer of protective lining in the gut. So combination of fibers.
And I'm glad you said about that, getting used to it, because sometimes people will be like, oh, I found this great chia seed pudding. And then they take it and they are like lying on the floor, writhing in pain. Too much, too fast. Too much, too fast. Go slow, add a little bit to your salad and get used to it. You can get used to it. Don't give up on it, but also don't go 0 to 60. So anyone's
Right.
listening out there saying, oh, I can't take chia seeds, I don't tolerate them. No, it's just too much.
Mhm.
You could tolerate them. It just needs time. Okay, so now tell us about the Hashimoto's gluten connection.
Yeah, and here's where the evidence that we were talking about. There is real evidence, real studies showing that gluten is related to increased Hashimoto's antibodies, the production of them, and removing gluten will make those antibodies go down. We see this all the time in practice too. And so what's happening is in the gut, and even if you don't have celiac, which if you have celiac, you're more at risk for other autoimmune conditions. But even if you don't have that, if you have an autoimmune condition, what's happening with gluten is it's breaking down those junctions in between the cells lining your gut. And then more things are able to come through and say hello to the immune system right underneath, and the immune system will react. And sometimes it reacts in a very negative way, which is autoimmunity.
I love that. And I love that you talked about the celiac, because so many people are like, I went to my GI and they said I don't have celiac and therefore I'm not gluten sensitive. Gluten sensitivity lives on a spectrum,
Mhm.
celiac being the worst, but
Mhm.
just because you don't have the worst doesn't mean you don't have the least. So you can be gluten sensitive, non-celiac gluten sensitive. There's actually an acronym for it. And if you have Hashimoto's, you most likely are. What about the concept of molecular mimicry?
Yeah. So, just to explain that. So sometimes external particles that our immune system is reacting to look similar to our own body tissues. And so it's a mistake the body makes and it starts attacking our own tissues. I think there was an early thing with Ciela. I actually remember learning about this back in med school. It's one of those triggers for molecular mimicry, as if you had Klebsiella infection and your body reacted to that. Looks like other body tissues.
Sure, but it's only allowed for that. But if you talk about it for gluten, then that's nonsense. Yeah. It reminds me when people talk about, like, unrelated segue. like IV vitamins. And people are like, well, that doesn't work. That's just expensive urine. I'm like, but why is it okay to give IV medication, which also is going to be partially excreted? But when we talk about vitamins, like it's nonsense. So yeah, sorry, little soapbox moment. For anyone contemplating, go ahead and get your IV vitamin infusions. It's fine. It's great. It's amazing. Okay, what did I not cover?
I mean, I think you did a great job. We hit all the key areas. Yeah, I think maybe it's like stress.
Yeah,
It's
tell us.
probably it's a big component of dealing with any kind of chronic condition, as it's stressful and then your body needs to get into repair mode. And so this chronic stress affects our HPA axis, so hypothalamic pituitary adrenal axis, and that gets disrupted. And that's one of the reasons that adrenal PCOS happens, is that that chronic stress and that HPA dysfunction. And so trying to incorporate some type of stress reduction activity every day, whether that's like going for a 10-minute walk or box breathing, worry journaling if you tend to be a worrier, getting good sleep, like taking magnesium glycinate at bedtime. Stress is just one of those things that you have to deliberately plan to have some kind of a strategy to combat, because we can't get away from it. We just have to do things to cope with it.
Yes, and that's really important because I feel like some people are like waiting for the stress to go away. I'll get to this when things get better, when we go over this hurdle. It is never going away, ever, ever. So understanding it, embracing for it, planning for it. That's really good. I like that. As we talk about strategy, but planning for it. If you don't plan for it, you won't be able to manage it because it's coming your way no matter what. And I'm going to add to that also making sure that for my perimenopausal women, a little bit older than most of the PCOS gals, you have to get your hormones right, because that's probably why you're also losing your resilience, because you need some hormones. I've seen so many people's anxiety just resolve when that estrogen patch hits. So let's get that there too. I know, a slightly different audience than the PCOS group, but
we help a lot with perimenopause too.
yeah, okay, so it's and the women who have the PCOS are likely going to suffer the most in perimenopause. If we don't intervene at some point, we're going there. We're hormonally imbalanced, and it's going to be a harder fall.
Risk factors definitely overlap for both PCOS and perimenopause. Yes.
Yeah. I say harder fall. You say risk factors overlap. I love it. You use the fancy words, and I just use the words, and it's great.
I can tend to be too clinical. I like your words.
No, I think it's great. You give like the clinical backing to my street cred, so it's great. A lot of times people come to me just to translate what their specialist just said. They're like, can you read this MRI for me? I'm like, yeah, it just says you're good. Everything's fine. So that's really funny. Amazing. But this is not something you need to power through. It is not something that you get a badge of honor for surviving. Learning how to cope with it and getting strategies and planning it's so pivotal for your health. I cannot overstress that. The more time I spend on the planet, the more I realize how important that is. Unfair question, but if there is only one thing that you could tell your patients to do, what would it be?
Well, gosh, we talked about quite a few of them. I'm picking one.
No, it's the worst.
I still have to go with balanced blood sugar, because even if you're stressed, it's going to be harder to cope with it if you have imbalanced blood sugar. So I'm going to go with that. That's a thing that you can do anywhere you are. You can do it. You can have protein, healthy fat, and fiber at your next meal, and you will feel better than if you ate, typical stress type food, which is not going to help.
True. Amazing. Okay. Tell everybody where they can reach you, how they can work with you.
Our website is rootfunctionalmedicine.com, and we work with both individual members and company-sponsored members. So you can sign up as an individual or tell your company about us.
Oh, that's a good one. I like that. It's a great idea. Amazing. Of course, I want to put the links and everything in our bio. So please, all women, but especially if you're PCOS or Hashimoto's, reach out. And let's get you feeling better. Thank you for being here.
Yeah, thank you for having me. Great discussion.
Of course. That's a wrap for today's episode of The Medical Disruptor. I'm so glad to have my microphone back. If this lit a fire in you, great. I hope you're really agitated. That means you're waking up. Share it with a fellow disruptor. Post it, tag it, text it. This is how the movement grows. And if you're ready to go deeper, grab the book, explore the course, or get some disruptor merch. Show the world that you're a medical disruptor. You'll find it all at drfatlamandre.com. This is the Medical Disruptor, and we're just getting started. Keep asking questions, keep asking for more, and keep disrupting.